Hello, good evening from Canberra, and welcome to tonight's IVF Australia Facebook Live session. My name is Steven Adair. I am one of the fertility specialists here in Canberra, and it's my pleasure to host this evening's live forum. My background is that I'm an obstetrician gynecologist with an interest in fertility. I've been working with IVF Australia for the past 5 years, but in Canberra since early in 2003. Here in Canberra we cover a wide range of patients, a large general population of women and couples with fertility issues. I do a lot of work here with couples and single women who look towards donor sperm. And some of the most challenging work that we do is working through not just the couples with primary subfertility, but also with secondary subfertility. And that is the basis around this evening's streaming. Tonight I was asked to talk briefly on that, but also to answer and to take any questions from you. So let me begin with the first question that was pre-sent by Nikki, and her question was, is age the main reason for secondary infertility? I think that there are a number of causes for secondary infertility. I think that many of them are the same as those causes for primary subfertility. I think that in broad categories, both secondary and primary infertility may be related to the male, but also may be related to the female. And Nikki's question about age certainly is important and relevant in all forms of subfertility. We are often asked if there's a cutoff age or if there's a timing of age. I think that women's fertility and egg reserve does fall with advanced age, and we often look perhaps at women who have been trying for greater than 12 months if they're less than 35, or greater than 6 months if they're over 35. So that's often the times when you would encourage women to perhaps seek some additional information through investigation or contacting their doctor and perhaps consideration of some blood tests or something like that. But I think age is important, and I think we should, along with a number of other lifestyle factors, we should always consider that. So I've just got another question here from Katie. I put a lot of weight on with my first child, and I'm now struggling to conceive. Could this be an issue? I think, as I say, IVF and fertility treatment is not always the first line of therapy, and I think some of these broad ideas as far as lifestyle are important. And I think that if the weight gain has also been associated with a change in the menstrual cycle and with the frequency of periods, then certainly there may be an implication of that weight gain. I think that unfortunately life with a toddler is harder to get out, and in the modern world, with certainly what we're experiencing with COVID at the moment, it's very difficult to get out and exercise. And trying to address some of those lifestyle issues preconceptually will not only help with fertility, but it will also help with a successful pregnancy. And it's a successful pregnancy and a successful live birth that we're really after. And so we would certainly encourage any changes in that arena. So thank you for your question. I have another question here about from Jane, which is, do you approach secondary infertility in the same way you would approach primary, or do you go straight to IVF? I don't think there's any fertility experts that I know and work with that would go straight to IVF without at least considering other alternatives. I think that we all want to see a successful pregnancy. As I say, part of that may be age related, and part of it may be influenced by any preceding pregnancies and whether or not there's a known fertility problem. So I think if this is just a delay in a second pregnancy, then no. I think it would be important to follow some of the investigation principles and perhaps to look at investigating the couple together. We know that a significant number of couples, the fertility issue actually lies with the male partner, and so investigating the male in a situation of secondary subfertility is also important. It may be that a couple wishes the interval between their two children not to be too long, and so perhaps if they are older or if they wish to have their children closer together, we're more likely to offer therapies, but that doesn't necessarily mean going straight to IVF. So I think that yes, IVF can be used even in the realm of secondary fertility if it's not been needed before, but certainly wouldn't be something that we'd rush to straight away. We would look to investigate and offer support as much as we can. We know that one of the commonest causes and one of the commonest issues when a couple already have a child is that having frequent enough and timed and regular intercourse is always going to be difficult with a newborn. We try to encourage intercourse on alternate days in the middle of the cycle, and even by helping with cycle monitoring, we're certainly going to try and up the pregnancy rates from that point of view. So I have another question from Julie, who asks, what are the investigation steps for infertility? That's a very good question. I think we begin by taking a history from both the male and the female partner if they are in a heterosexual relationship. I think obviously single women, their history, and women in a same-sex relationship, we want to know their medical history. We want to understand some of the simple background as far as their gynecological history and their menstrual cycle in particular, because many women who might have less frequent periods or may have periods that are more spaced out may have a tendency towards polycystic ovaries or polycystic ovarian spectrum, and that can lead to less ovulations and less regular ovulation. So I think we would look at their history. I think all of us would do some baseline bloods, including thyroid and other female hormones. We might look at an ultrasound of the pelvis, and then we would go on and investigate the male partner. I think that all these things can happen together, and then given those history and some of those initial investigations, we might look on at some secondary investigations and look at tubal patency. So I think those are some of the baseline the baseline investigations that we would begin with. I hope that's helpful. I've just got another question from Sarah. I'm on iron tablets and Elevate. Would it be best also to be on Q10 for a few months before starting IVF for egg health? There are a number. I think that iron and or vitamin D and Elevate for the folic acid are the keys. Particularly the folic acid is a key preconceptually. Some of the evidence around coenzyme Q10 is less clear. Certainly won't do any harm, but certainly the benefits as far as preconceptual health are in both diet and exercise and preconceptual folic acid. So I think from my point of view, that's certainly something I would encourage you to consider, Sarah. So thank you. So I've just got another question here from Casey. I want to know, after an early miscarriage, how soon can you start your next FET? So an FET, a frozen embryo transfer cycle. So Casey, the first of all, I'm very sorry to hear that you've gone through a miscarriage. Unfortunately, miscarriage is very, very common in human reproduction. We see it, or I see it, in 1 in 4 to 1 in 5 of all pregnancies, so probably more common than any of us talk about. It doesn't go up with fertility treatment, but it certainly doesn't. Fertility treatment doesn't necessarily prevent early pregnancy loss. Many women will choose to have conservative management, will let nature take its course, and once that happens and the bleeding settles or the miscarriage is completed, then it can often take a couple of months for the cycle to return to a regular cycle. And so I suppose I would certainly suggest at least 1 month of a break, if not perhaps 2 cycles, to ensure that the preceding pregnancy is complete, the cycle has returned, so that, as many of us would do, allow you the option of a natural cycle with a frozen embryo transfer cycle. Medicated cycles can add to that as well, but certainly it would be my opinion that to give yourself a couple of months to make sure your menstrual cycle returns. And also, I think probably the appropriate time for you to get the support and to come to terms with the pregnancy loss, because I think that this journey is hard anyway. I think that pregnancy is hard anyway, and I think that the ups and downs and the good days and the bad days can become more extreme. And so I think it's important that you give yourself the time and that you also get the support that you require. And certainly if you ever did need further support, I'm very sure that either your own fertility specialist or any of the counsellors or fertility nurses through the organisation will be happy to provide some support. So I hope that answers your question and provides you with a little bit of help. I've got another question here from Michelle. Michelle says, people think I'm selfish for wanting more children when I've already got one. I really want another one, and I don't know why it's not happening this time around. Do you have any advice? I would say to you, Michelle, that I don't think that it's selfish in any way. I think that many families, including my own, have more than one children. So I don't think it's selfish in any way. I think that I perhaps asked a question a little earlier, that it's not unusual for for a couple or a woman to have a 6 or 12 month inter-pregnancy gap. I think by the time you finish breastfeeding and your cycle returns, it can take a little time for that to happen. I think obviously you're going to be a little bit older, and if you have, as was asked earlier, put weight on during the first pregnancy, then there may be some issues around some of those lifestyle things that we can look at to adjust. The causes are the same for any pregnancy or for any early delay in pregnancy, and I think when we look at it, we look at ovulation, we look at sperm, we look at tubes, but I think lifestyle and also the opportunity to have regular intercourse or regular timed intercourse can be difficult, and sometimes even some simple measures like cycle tracking or some of the fertility apps will at least give you an indication of when it's possible. I think it's important not to stress, and I know that's easy for me to say, but I think that sometimes it can become overwhelming, and I think it would be important not to worry as much as perhaps you have done, and to be reassured that it will happen, and that if it doesn't happen, then we can certainly look to help you. So I hope that's useful. So there's a question here from Alana that asks, what can you recommend on increased 17-hydroxyprogesterone in bloods? Alana, I guess I would need to understand a little more information, because it would depend when in the cycle those bloods were taken. I hope that they were done as part of a panel, and perhaps it may be that they were done in the second part of the cycle. So there may in fact be not be of a major concern. I think that obviously, having found that, it might be of benefit to consider an ultrasound test to look to see if there's any other guidance. I think that it's probably a panel of something that we could do. And I think obviously, having done those, talking to the GP and perhaps talking to an endocrinologist will help in monitoring that and controlling some of the other issues and factors around that. So I hope that's helpful for you, I mean, I think that it, as I say, very much depends on when it's done, but also in a bigger picture with some of the other tests. As I say, an ultrasound would be important, and talking to an endocrinologist will certainly help. Then we can take that from there. So there's another question here from Jamie, and again, Jamie, I think when you ask, is there a benefit to investigate my husband even though we've already had a child? So I think that male factor fertility does add both to secondary subfertility as well as to primary subfertility. I guess it would depend what lifestyle things have changed for him. If his job has changed, if he's a more sedentary lifestyle, particularly in the current environment, has he started any new medication? So I think that there absolutely is a benefit to consider testing, because it may be that when the sperm test is done, it might be that it's not that it's grossly abnormal, but there may be minor things with the motility or the numbers of sperm that might mean that actually to conceive the first time was actually a bonus, but to conceive again we might be able to contribute and add something to the therapeutic options for you both as a couple. So my thought would be that certainly the investigation for a couple with secondary infertility should be along the similar lines, and just because they've had a successful pregnancy doesn't mean that some of those first principles couldn't be followed. Sorry, so Alana, I see your answer was halfway through the cycle, and so yeah, I mean there is a rise, but I think that perhaps it would be worth considering some of the other investigations in and around that. Okay. I'm just reading some of the comments from Alana, and I understand that, and I think that perhaps it would be worth having tried a number of issues, and I would recommend probably taking this to your fertility specialist and having a conversation with he or she, because I think you've certainly been through a number of treatments there, and you know I think it's worth seeking an opinion. I'm glad you've got an ultrasound booked, and yes, it'll be interesting to see how that comes across. I also wanted to say to Casey, thank you for the comment about the coenzyme 10, but just please make sure that the doses are appropriately recorded. Now, Camilla has asked a question about her husband, who has, I hope you don't mind me sharing it, who had a vasectomy reversal 2 years ago. The comment really post vasectomy about testosterone. Testosterone can actually work in a negative way, Camilla, so I would be very wary about taking men taking testosterone supplements. I think that can actually be a negative rather than a positive thing, and I think clearly the information about whether or not there was active and motile sperm in the semen analysis post vasectomy would be important, but I would be very wary of taking additional testosterone because it can in fact have a negative influence. So I hope that's of help to you. So I think there's just another comment from Alana. I think, Alana, I'd be very happy to talk to you offline about this. I'm not sure where in the country you are, but very happy to talk to you perhaps through our 1-800 number, and certainly if anybody has got any questions after tonight, then the IVF Australia number is 1-800 111 IVF or 1-800-111-483. So I hope that's I hope that I can help you going forward, and happy to help. And we can certainly work through the time difference. Okay, so I'm just looking at the next question here. So Shaharna's asked a question of what time frame, once diagnosis confirmed, can treatment start? I guess the answer to that would be that we can confirm a number of things on a basic semen analysis, but that would be one of the first parts of our investigation. We would also look a bit like when we investigate the female partner. We would look at some bloods. We might consider looking at some genetics, and it would be important, I think, for the couple as well as the individual involved to see if we can get some answers as to why. Many clinicians would recommend repeating the semen analysis more than once to make sure it's not an aberration, but obviously it depends on the results the first time around. But I think that doing some of these investigations are important to try and at least provide further information for the guy and for the couple before we would consider the treatment alternatives, because very much like any other form of fertility issue, the treatments that we have available are then going to be directly influenced by the causes of the problem. So I think some of the tests will return quite quickly, but some of the genetic tests that we often have to look at in fertility investigation for both guys and for women can take 8 to 12 weeks to return. So that's often the controlling factor, is that waiting for those results can then lead to a number of delays of up to several months, but usually not much more than that. And I think certainly we try to make the investigation process as timely, but that time also allows not only for these investigations but also for consideration of the implications of the results and of the discussions in and around the various treatment options. So I think I think it would be wrong to give you a specific time frame, but I think most of us try and deliver these investigations and pathways to find answers as in as quickly a time as possible. So we're not delaying this for you because we know how much this gets concerning for you. So I hope that answers your question, Shaharna. There we are. So yes, so just one more question there from Susan. She says, I am in my late 30s and my youngest child was born about 6 years ago. How long should I wait before coming to see my GP or see a fertility doctor? I think, Susan, really the answer to that is that when you are over 35, if you've been trying for longer than 6 months, and you've got no other health problems, then I think it is probably worth considering having a conversation with either your GP or with somebody else. I know that the fertility doctors are going to be very interested to help you. I don't think it means that you have to rush straight to IVF, but I think as you approach towards the end of your 30s, I think it'd be important to at least look at this and see if we can come up with some treatment strategies or investigation regimes perhaps that would help you have a second child if that's what you wish and desire. So I just want to thank you all very much for attending this evening. I hope that tonight has been informative. I hope that I've been able to answer your questions and queries clearly and as helpfully as I can. As I said before, IVF Australia is wide-ranging across various states and territories, and the helpline, the 1-800-111-IVF or 1-800-111-483 is there to provide both information on the services that the organisation provides, but also to put you in touch with your local clinic or with a clinician closer to you that can help you. Most of the helplines run in office hours on Eastern Standard Time between 9 and 4 Monday to Friday, but certainly the organisation will do their very best to try and help and answer some of the questions. And certainly from my point of view, it's been a great pleasure to talk to you all, and I will certainly follow up with the Information Centre, and if I can be of help, I'm very pleased to help in any way that I can. So I would like to wish you all a safe evening, and thank you all very much for listening tonight.